Good afternoon. My name is Candy Chitty, and I'm going to be the presenter today. And we're going to talk a little bit today, probably the next 30-40 minutes, on the most common pitfalls to avoid in a HRSA operational site visit. I'm going to give you some tips on how to prepare and plan and how to approach the operational site visit as you begin to if you're notified or you're having one that's coming up, you've already been scheduled, or at some point in the future you will get notice that you'll be receiving an operational site visit. Okay, so this is just the introductory slide. We're going to take a little bit of a soft approach to this, and we're going to play as if we are going to be setting the stage and having a Tony Award-winning performance as you prepare and actually have showtime, is what I call it, when the team arrives and you actually experience your operational site visit. So this is how we're going to set our stage for the next 30 or 40 minutes. We're going to start with a prologue, just like a nice Broadway play, and then we have three scenes that we're going to talk about. One is setting the stage for your OSV. Scene 2 is going to be backstage preparation. Those are things that we'll talk about that you will be doing backstage before it actually starts. And then we're going to go into the stage 3, or scene 3, and that's the actual showtime. After that, we're going to look at some cast of characters, and then that's going to be main characters, some supporting roles, and props. So let's jump in with a prologue. So as you all know, sooner or later, every health center will receive notice that it's time for an operational site visit. And the acronym that's commonly used for that is an OSV. So if you are a new access point, maybe you haven't been scheduled your operational site visit, just know that new access points are to receive an operational site visit within the first 15 months of their project start. So you can kind of calculate where you are in terms of project start, and within that 15-month time frame, if you have you been scheduled an OSV or not. For everyone else that's been around for quite some time, your OSV is scheduled at least once during your project period. And as you know, project periods have been shortened from 5 years to 3 years. So it would be within your 3-year project period, or if you happen to have a 1-year project period, you would have one within each of those years. So in the midst of our never-ceasing day-to-day health center activities, the OSV is also one of those, when you get that notice, it's like, oh my, here we go again. And it's not viewed as a positive opportunity. And it actually is a positive opportunity if it's approached that way, and we'll talk about that a little bit. But the opportunity, it gives you an opportunity to present your accomplishments and your best practices, because everybody has some things that are done uniquely that are considered a community best practice, to self-assess your readiness so that you're going to do that before the curtain rises, and your readiness, and then assess your performance against the actual program requirements, and then actually to tap into the expertise of the consultant team for technical assistance. If this isn't done, then it really is a missed opportunity for making this OSV a positive and valuable experience for you. It's true that the consultant team is first tasked with opportunities, first tasked with the task of making sure that they go through and assess and record the findings for the program requirements. But also during that assessment, there are opportunities that always arise that allow health center staff and the board of directors to receive technical assistance specific to some of the needs. So it's important as you prepare for the visit, and actually on the first day of the visit, is to make those needs known so the consultants can address them as time permits. Most consultants on the team have many years of experience in working at health centers or providing services to health centers. As a result of that experience, they come combined with the knowledge gained when doing OSVs across the country. And consultant team members bring invaluable knowledge and best practices direct to you. So let's look at scene 1. Scene 1 is setting the stage. Your healthcare facility is a stage upon which you carry out your HRSA funding obligations by compliance to those 19 program requirements. Let's ask a couple of questions. If you were to have an OSV today, how ready would your stage be? Are you currently ready? Do you continually maintain readiness for an OSV? As there are some instances in which OSVs may be done unannounced. That's not a common practice, but it could happen. Does your stage adequately show good understanding of compliance requirements? So, and when I say stage, I'm talking about everyone in the health center, not just senior leadership, not just board members, but everyone in the health center. Do they know what the 19 program requirements are? They may not have to know them intimately or comprehensively, but do they know what they are? So if someone asks someone in the back office or front office, or ask someone in IT support, you know, do you know what HRSA governs your health center on? Then they would be able to say, yes, we have 19 program requirements. That's what we call setting the stage, making sure everyone is well informed and prepared. Here's some common pitfalls. And these are things that, as we go through, think about, are these pitfalls that you might be experiencing, or if you've had an OSV, are these some of the pitfalls that you actually did experience during your OSV? Because the purpose of this presentation is to help you overcome that, understand what those are commonly, and then make sure that it doesn't happen. You can address them. So the first one is lack of understanding of the purpose, goals, and objectives of the visit. Why the OSV? What's the purpose? Well, the purpose basically is to strengthen your ability to carry out your mission and to carry out the mission of HRSA 330 grant programs. And that is through the health center program requirements. By doing so, this helps you to provide access to culturally competent, quality healthcare services to communities in need, which is your target population and service area. So the goal of the OSV is to come in and bring external eyes, external expertise to your organization to fully assess and then point out things that you could improve upon. Oftentimes we're asked, is this a punitive visit? It's not intended to be a punitive visit. It's intended to be something of helpfulness, collaboration, but yes, there is a degree in which program requirements that aren't met, found not compliant, that there can be action plans that need to be addressed post-site visit. You have opportunities to address all of those issues after the site visit. You have quite a bit of time to do so. So in my opinion, this is my own opinion, the time frame that HRSA gives you to correct your deficiencies is plenty, as long as you continue to work on those and get those removed in that time that they give you. Lack of system-wide education for staff and board members related to the program requirements. Oftentimes this is kind of held close to the chest with senior leadership and maybe the board chair or maybe the executive team of the board, and not really communicated out through the entire organization about what's going to happen. The OSV has been scheduled, here's the purpose, here's how we're going to approach it, here are the program requirements, and here's some of the things that we need to think about that are related to each of the program requirements. So it's encouraged that you will spend some time to do some system-wide education for your staff and your board members about the program requirements. Overall, all 19, and maybe more of a targeted education between the program requirements that most affect certain people. For example, on the board, many times as a best practice that I see with board members in health centers is that the board actually looks at a program requirement maybe one per meeting, and they really get into the details of each program requirement, what it is, how ready are we, and this is done on an ongoing basis so that at any given time when an OSV, you get a notification for an OSV, that you're fairly ready to go. The third is setting unrealistic expectations. Unrealistic expectations, I can tell you, is that making it well known within the organization or maybe even your partnering or neighboring FQHCs that you're gonna get full compliance, 19 out of 19. I'm here to tell you that's probably an unrealistic expectation, and that sets the stage for some disappointment or frustration on the health center part if that's the expectation that's met. It's a great goal to have, and it's a great anticipation, but oftentimes that's not a realistic outcome. So it's good to talk about, you know, what is realistic, and one way to do that is to actually do your readiness assessment and go through the 19 program requirements and be very open and transparent and know where your vulnerabilities are. Know where you may or may fall short a little bit in one of the requirements or maybe more, and take that approach that, you know, it's okay. We know where our vulnerabilities are, and we're going to look at this OSV as an opportunity to learn how to be compliant or how to make things better. Common pitfalls number 4 is lack of complete documentation. And I put in parentheses minutes. Oftentimes, you know, minutes tell the story of your organization, whether it's board minutes, whether it's provider meeting minutes, QA minutes, committee of the board minutes, staff meeting minutes. That is your archiving, and that is your story of what goes on in the organizational processes and procedures and operations. Many times minutes when they are presented are vague, incomplete, and it's very difficult to be able to determine whether or not certain operational processes are being carried out. When you talk to staff and verbally, you get the sense sometimes, yes, they are, that we do meet, that the board meets, and we do these things, and we do privilege providers, and we do approve budgets. But for some reason, minutes don't always reflect that, and that is the area in which many times things are left as a non-compliant or not met in a program requirement because documentation is not complete. Policies and procedures outdated with poor tracking of oversight, review, and approval. As you know, if you've been through an OSV or if you've looked at the program requirements in HRSA Site Visit Guide, you'll see that there are documents, many documents that the consultant team will look at that are actually identified as having to be policies and procedures. An example of that would be your sliding fee discounts program. It would be maybe your credentialing and privileging, hospital tracking, lab tracking, billing procedures, financial policies, just to name a few. And sometimes these policies and procedures are outdated. They haven't been reviewed in 5 or 10 years. They may not be based on evidence-based medicine. There's not the way the formatting of policies and procedures are that it doesn't yield itself to tracking and oversight, so it's unclear as to when the policy may have been effective, when it was last reviewed or revised. Sometimes the board may approve and review policies, but it's not in the minutes, and the actual policy itself doesn't have what I call a policy attribute. So these would be things to think about as you're beginning, if you're reviewing and looking for readiness, is to look at your policies and procedures, and do they give a good history of when they were created, when were they reviewed, what kind of resources and references are used that are evidence-based in creating these, particularly in your clinical protocols. Are we using evidence-based medicine? And the approval process. Waiting too long to start preparing for the visit. This is a common pitfall, and many times it's thought, well, I'll prepare after we have our pre-call with the consulting team. That pre-call usually comes about 2 weeks, sometimes shorter, sometimes a little bit longer, but it's average about 2 weeks before the site visit. And I could tell you that's probably not enough time to prepare. If you've been through an OSV, you're quite familiar with the lengthy document request list that comes from the consulting team. That's usually 5, 6, 7 pages worth of documents that need to be pulled together and organized in a way so that they're available on the first day of the visit. So usually it takes, you know, probably a good 2 to 3 months to prepare. Hopefully that you get enough time between your notification in order to do that. But rule of thumb and best practice is to take the approach that we're going to stay prepared at all times, and that's through ongoing training, ongoing readiness, ongoing education, of those program requirements and where we fit in terms of all of the things that we have to comply with. Not successfully completing the 3 Ps. You're probably thinking, what is that? What are the 3 Ps? And I'll talk about that in future slides. But the 3 Ps, just to let you know, is a positive approach is the first P. The second P is planning. And the third P is preparing for the OSV. We're going to move to scene 2, and this is backstage preparation. Health centers are given prior notice of a planned OSV and usually have plenty of time to prepare for the visit. Preparation should start prior to the pre-site visit call with the consulting team and project officer. So as soon as notification comes, then the preparing stage should begin and the planning stage should begin. There's a lot of resources and tools out there that are specific to OSVs, and then there's resources that are supporting documents for OSV helping you meet the requirements. And I've got several slides with some links, resource links to some of those resource tools. Know that the consulting team has approximately 2.5 days to complete the comprehensive assessment. That's not a lot of time. To avoid roadblocks, challenges, and perhaps frustrations, it's best to be very prepared to receive the team from the moment they come in the door on the first day. Now we're still in the preparation scene, and I pulled out from experience of doing OSVs and working with the colleagues of the consulting team. I'm a clinical consultant, and then the other members of the team are the financial and management consultant and the admin governance consultant. So from the experience of doing OSVs for the last 10 years, there's 5 that tend to cause some challenging issues among health centers, and these are the ones that more commonly than not have issues with being met. The first one is program requirement number 2, which is required and additional services. You'll notice most of these, because they are what I call multi-criteria, it's just not one requirement within that requirement. There's multiple things and elements and criteria that you have to meet in order to totally meet the whole requirement. Makes these more challenging. Some challenges in required and additional services is the fact that there are many required services and additional services, and that comes from your Form 5A. As a result of that, the consultants are looking at Form 5A, and they're looking at those 3 columns in which you've selected how you deliver your services, your required and additional services. In looking at that, in the first column, those are the things that you do directly by employees of the health center. And oftentimes that's reviewed and looked at as through a tour, looking at staffing profiles, going through a tour of your facilities to make sure that the things that you say you do direct are actually operational and they're within your locations. Then when we get into column number 2, these are services that you don't do directly, but you have a contract in place, or it's called a formal written agreement. Oftentimes it is a contract, and the reason why is because these are services that are provided, that you contract with, that you actually pay for. So they do the service, they submit a bill, and you pay for the service. So because there's money exchanged, oftentimes that's usually in a contract. And then the last column is column 3, and these are the services that you don't do directly. You don't pay for the services as a contracted service, but you do it through referral arrangements. These also require a formal written referral arrangement, which is more of an MOA or a MOU type of document. Because you can see the amount of documentation and the different types of documentation that are required, particularly in column 2 and column 3, oftentimes there's one or more of those that are not available. It is okay for the consulting team, particularly if you're a very large organization and you have a lot of these agreements and arrangements in place, that they don't have to look at everything. They can pick, some agreements, can pick some services and look for some things, but they don't have to look at all of them. Program requirement number 3 is staffing. This one has multiple elements, and there's 2 or 3 primary elements within it. The first is that assessment that you have the appropriate staff, composition and size to carry out your services that have been outlined in your Form 5. So we're looking to see if you do OB/GYN, do you have an OB provider? Pediatrics, do you have a pediatrician or you have family medicine? Looking to see that that composition is there. A second component is that they are appropriately credentialed. And the third component is if they're appropriately privileged by the health center to see patients and to carry out their services. The challenging component of this one, and this is one that clinical consultants are reviewing, is there's a lot of nuts and bolts and requirements for credentialing and privileging. This is the area in which oftentimes becomes very challenging. And making sure that you've got your policy in place and that the policy matches the PIN, which is PIN 2002-22, and the privileging PIN is 2001-16, so that you've got all those pieces in place, that the policy addresses them all. The policy has been reviewed and approved by the board, and there's documentation either on the policy itself or in board meeting minutes of that approval. And then the implementation of the policy. In looking to implement and demonstrate evidence of appropriate implementation, we're going to be looking at files, provider files, and this is licensed independents, which are your providers, your physicians, your advanced practice providers, dentists, some behavioral health if they practice independently, and other licensed and certified providers, which are only those that might be registered, licensed, or certified and don't function independently. An example of that would be RNs, LPNs, certified MAs, certified nursing assistants, registered dietitians, just to give you a few examples. So looking at the files, are all the pieces that are required in terms of credentials, which would be license, examples would be NPDB queries for your licensed independents and perhaps your RNs and LPNs, DEAs, board certifications, current competence, which might be a delineation of privilege form. It could be peer references. All of those documents, are they organized? Are they in an appropriate place? Have they appropriately been verified? Is that documented? And if it's documented, what source was used to either primary source or secondary source, and the date that it was verified. So as you can see, that is a lot of paper, a lot of activity, a lot of verification and documentation. The privileging component comes in the fact that there is a review by a medical director, a credentialing committee, a board committee that actually reviews and then presents it to the board, and the board minutes or some board documentation shows the decision of privileging for each of the licensed independents. And for other licensed, there's documentation of a supervisory review and approval or some decision as to the privileging of other licensed or certifieds. Many times it's the privileging component that presents challenges to this requirement. And it's not that it may not be done. Oftentimes it's lack of good complete documentation. Program requirement number 7 is sliding fee. The new site visit guide, which is it applies to fiscal year 2015 and it was issued in November, has expanded this program requirement. It used to, when we're looking at, go back to program requirement number 2, requiring additional services, when we're looking for those agreements, those specific types of agreements for the types of services that you provide, you're requiring additional services. Previous site visit guide, the actual language of those agreements was in Program Requirement 2. It's now been shifted to Program Requirement number 7. So within that, the person that's reviewing that, the consultant reviewing, is going to look at those agreements and see if there's certain components within them. I won't go into great detail. It's in your site visit guide, but just as a whole, it talks about a discounted program. So are there discounted programs available for patients that are being seen for services in column 2 and column 3? They don't have to be the same sliding fee discount schedule or program as the health center, but there needs to be some assurances that patients have access to the services. Again, another challenge is that the sliding fee PIN has been recently updated. And I would encourage you, if you haven't really absorbed that, to get a copy of it. And their FAQs, I believe there's also a presentation of the sliding fee, and really understand all the components of that sliding fee. Program requirement number 8 is the QI and QA. This also is challenging to meet because it has many, many components to it. It goes into the realm of clinical protocols, your medical record patient confidentiality, looking at medical record policies, looking at patient safety, looking at your QI and QA plan, how do you implement that plan, who has oversight, day-to-day oversight and accountability, who has ultimate oversight and accountability, and in all of those documents you're looking at, then taking it to the next step, which in the site visit guide talks about the periodic assessments, evaluating results, and implementing change. That is your CQI process. The challenge in this particular one is often related to the CQI process. And it's not that it's not being done. In many aspects, the process is in place. There's a lot of great activity that's going on. However, it's not well documented, either in QI/QA committee minutes and or through board reports and communication about the activities that are going on. What are we measuring? Are we meeting our goals? If we're not meeting our goals, what kind of actions are we thinking about implementing? Did we implement them? Did we go back and measure again? And how did we do? Did we make a difference? Did it get better? Did it stay the same? Did it get worse? And that's periodic, and that CQI cycle is an ongoing dynamic cycle. Program requirement number 17 is board authority. And again, this has many, many pieces to it. It's quite lengthy. It's a challenging requirement to meet. And on top of that, there is a new governance PIN that has been issued that supersedes all the other PINs and PALs that have come before it. A main challenge with the new PIN and the board authority is the bylaws. There's a very detailed section in the new PIN about what the bylaws must have, and I don't have it in front of me, but it's probably a good 8 to 10 bullets. And if bylaws haven't been reviewed recently, again, then I would recommend that you take your bylaws and review them against the new PIN and make sure all of those bullets have been addressed or can be found within your bylaws. And if not, they may need to be revised and reapproved. Other things in board authority is holding monthly meetings, reviewing and approving health center general policies. Usually it's all policies that go before the board. The PIN does outline specific policies. It's included but not limited to is how the verbiage is, but it does give you some idea of the ones that must be sent to the board for review and approval. Looking at the annual budget, approving the budget, certain things of review and approving of grant applications before they're submitted, and that's the key word, is before. Those are some of the things that are often seen as some challenging components of the requirement. So you can see out of 19 program requirements, we have 5 that cause more challenges than others. So here's the 3 P's: positive approach, planning, and preparation. In a positive approach, just know that the OSV is what you make it. and the approach you take impacts the overall tone of the OSV and drives the OSV experience. In situations where health centers have done a full comprehensive assessment of readiness and they understand their vulnerabilities, especially in new starts, it's very difficult to achieve full compliance for all the 19 program requirements. And understanding that yes, you're a new start, you're a new access point, and we know that we have some vulnerabilities in certain areas. Knowing that and taking a positive approach to say, you know what, we already know that we have some issues with this particular aspect of the program requirement, and we would like some assistance with that. If there's time and as time permits, as a consultant myself that does these, my favorite part of an OSV is having that time to provide that kind of experience and knowledge and share information and to help health centers overcome some of their vulnerabilities. So setting that tone is very important, and understanding where you really think you are. Managing expectations, we did talk about that earlier. That's so important, is to really understand what the expectation and to manage those expectations, not just among senior leadership and board, but across the entire organization. Because the organization is going to be impacted by the OSV, whether it's just through a tour, the consultants coming through and looking and visiting the centers, which they may or may not ask some questions as they go around the centers. But just if they don't, it's just knowing that they're on site, and this is the reason why. Next is planning. This is very important, and this is all about not even preparing, but just planning for what we're going to do. The first bullet is reviewing the site visit guide thoroughly. It's a very good document. It's been recently updated, and it's kind of like the Bible that you could go through and you could say within it, okay, here's the program requirement, here's all the things they're looking at. It has great resource information in it, some great links. This is what the consultants are looking at as they go through and assess the program requirements. So if this is a great way for you to establish your own readiness, is to do that exercise and take that document. There's a place within it so that you can actually put a yes or a no or comments of where, are we doing good in this area? Do we need to, to do a little bit better over this area? There are some things we need to fix or make sure that we have in place before the OSV. That's all part of the site visit guide. It's a great tool. Taking full advantage of the pre-visit teleconference with the consulting team and project officer is invaluable. This call happens, like I said, probably usually about 2 weeks before the site visit. Sometimes you get a little bit more time than that. And this is the opportunity to meet the consultants by phone and to review certain things, verify, confirm, and to really get a sense of what's going to happen on the site visit. So things to address, and most of the time the site visit team lead, the consulting team lead, will make sure all of these are addressed. But just in case that's not addressed, I wanted to give you some of these areas that you might want to bring up and address with the team. The first is the staff the team wants to interview. Each of the consultants will spend some time interviewing some of the staff, and I will towards the end of this, we'll give you some insight as to types of staff that will be interviewed most commonly. So ask them, who do you want to interview? And then work through the agenda, because they'll be presenting you with a draft agenda of when those interviews would best be held. For example, CMO. As a clinical consultant, I always want to speak with the CMO, medical director. But I don't want to pull that person away from clinical activities and patient care if at all possible. So we may on the agenda say, well, I want to speak with the CMO on the first day, or maybe the afternoon of the first day. If that's a clinical day, then it's quite possible to do it on the second day. Most consultants that come on site are very flexible and understand that patient care comes first and will work around scheduling. As a FYI, on the first day of the site visit is usually a day in which the consultants are buried in the paperwork. So they're looking at all the documents that you've provided from the document request list, and they're doing that pretty much the whole day. Sometimes interviews may start at the end of the first day, but usually most of the interviews are done on the second day. The first day is usually also the tour of the locations. And that brings us to the next point. Verifying the address of all locations are correct. And if they don't do that, it would be nice for you to go ahead and look at the agenda. The agenda usually has the address at the top, and that address comes from materials and information that's provided to the consulting team. And oftentimes it's not correct. You may have moved, or that address may be an administrative address, and it might be better for the consultants to be at a clinical location. So all that said is to just verify the address of all locations and verify that they're correct. As part of that, verify which location the team wants to tour. Sometimes it's all of the locations, particularly if there's one or two and they're in close proximity. Others, if there are multiple and you have a lot of locations, then that would be a good conversation to have at the pre-site visit call, is to nail down which locations the team wants to go visit. Sometimes if you have dental at another location and it's separate, you might want to go see the dental. And you might then see the primary care, or behavioral health may be at a different location. So it all depends on the types of sites you have and where they're located. But that could be confirmed during the pre-site visit call. Schedule a team meeting with board members. The team is going to want to meet with board members, and they usually will in the draft agenda put out a certain time or day that they would like to do that, but know that that can be altered. We know board members usually have jobs. They volunteer their time to be a board member, and they have other responsibilities. And I've seen where we've met with board members in the evening, we've met with them during lunch, we've met with them early in the morning. That can be flexed, but it's important that that's ironed out, so that gives you as a health center plenty of time to notify the board members of the intent of the meeting and when it's going to occur, so that we can have as much board representation as possible. Mutually agree upon the site visit agenda. That comes from the discussion of primarily of the bullets, the 4 bullets above, which are all part of the draft agenda, and making sure things are moved around and verified and confirmed so that the agenda is pretty finalized by the end of the pre-visit call. Discuss any documents on the document request list. That should come before the pre-site visit call and give you an opportunity to look at all of the documents. If you have questions about, sometimes there's questions about the naming of the document. You may have it called something else than what is written on the list. But all those questions have an opportunity to go through that and have your questions answered, and to discuss with the consulting team how the consultants wish to have the documents presented. More often than not, it's preferred to have an electronic format. Such for anything that you have electronic, we're not asking you to take it and print it off. If you already have it electronic, you could put it out on a shared file system with access to the consultants, or put it on a flash drive, USB, because oftentimes we go back to the hotel and we do work in the evenings, because as you know, we only have 2.5 days to do a very large amount of work. If you have it on paper, that's okay. It's not often required that you scan it and make it an electronic format. And many times committee minutes, especially board minutes, are left in paper format, so we can see original signatures, contracts, and such. So all said is to get a sense of some of the talking points during the pre-site visit call that you may want to address. And then again, is verify the purpose, goals, and objectives of the OSV so that it's well discussed, well understood, and everyone is on the same page as to what to expect, so that you can manage the expectations at your health center. Preparation. To prepare, want to organize documents that have been requested as per consultant preference. There's many ways you can organize documents. Some best practices that I've seen is where they've taken each of the program requirements and they've done it and organized it by program requirement. Sometimes they organize it by type, whether it's finance, whether it's clinical, or whether it's governance. But I will tell you that there's going to be overlap. Contracts and agreements are usually looked at by all three consultants. Minutes are looked at by all three consultants, job descriptions, and so there's some common things, and hopefully you will see that when you get the document list of the things that will be common across all three. But organizing documents is very important, and having those documents available and ready for review from day one entrance conference is important as well. Send documents requested prior to the visit in a timely manner. There's going to be a few documents that each of the consultants is going to want to see ahead of time so that it can help them begin the preparation process and to understand and learn a little bit about your organization before they come through the front door on the first day. Some documents can be supplied either by the health center or sometimes the project officer. We most often want to see some UDS numbers if you have them. You know, your most recent SAC. I personally like to see your QI/QA plan. But your document request list will have those highlighted or bold-faced. It's very clear as to the documents that are being requested ahead of time. So to get those to the consultants as soon as possible is a big plus. Prepare for the entrance conference. The entrance conference is going to be at the very beginning, the very first thing of the first day. And the entrance conference is an opportunity for introductions. It's an opportunity to again set the stage for the site visit, the goals and purpose and objectives of the site visit, an opportunity to review the agenda, because sometimes things change, and so it's an opportunity to say the agenda is either confirmed as it is, or we may need to move some things around. And it gives an opportunity for the health center to do an overview and highlight their health center. So I'm going to jump to the bottom bullet so I can talk about that, and then we'll jump back up to the next to the last bullet. Prepare a brief 10-minute presentation that highlights your health center. Oftentimes we see this in a quick PowerPoint, but it doesn't have to be. But it needs to be brief and focused and clear and about your health center. A little bit about the overview, the history of the health center. What are your accomplishments, the things that you're most proud of? That's always a delight for consultants to hear. It's like, what have you been doing? What are some things in the community that you've been helping with? And then talk about some of your challenges. What are your challenges? Talk about your strategic plan. Where do you want to grow if you want to grow? It gives you that opportunity, but 10 to 15 minutes is usually the amount of time that is allowed, or it can be allowed during that entrance conference for that kind of communication. It also allows you to formulate your thoughts. So in case you're a little bit nervous when the team comes on site, it's a way to have predetermined the type and information that you want to present. Let's go back up to the topic, the bullet right above, which is communicate to all health center staff and board members the purpose, goals, and objectives. Again, this is all part of educating, making people feel at ease as to why the team is on site, how long they're going to be on site, some of the things that they may be looking at, interviewing for, and particularly board members. It's board members understanding their role in the OSV. That's very important as well, and just communicating that to everybody. Here's some resource links that I'm making available to you. The site visit guide, as I said earlier, has been recently updated, so if you don't have one, that at the bottom says November 2014 / fiscal year 2015. That's not the most current, so there's a link for that. Scope of project. Scope of project is program requirement number 16, and although I did not put that in as a challenging requirement, and the reason is because of the scope validation project that was done last summer, and I think it's now closed at the end of this year, kind of helped with that. But just know under program requirement number 16, the scope of project, what we're looking, the requirement actually is looking to see if the things that you have on your Form 5, 5A and 5B actually are correct, so that all the X's are in the right spots. And if there is an error, then that will be noted and program requirement number 16. So I've listed some pins on scope of project. The last one I believe is on specialty services. Form 5A, this is a couple of documents. There's a lot of confusion around, what do those columns really mean? And this is two really good documents. One is, it talks about the service descriptors, and then the second one talks about the column descriptors. And it's a yes-no kind of a table, and it says if you do this, then it goes here, and I just find it very, very informative, and it helps bring clarity to how to fill out the Form A. It also can help bring clarity for you to determine whether or not your scope of project is correct and accurately reflects what you're actually doing. The sliding fee pin, FAQs and PowerPoint link is here. The new governance pin and the PowerPoint associated with that is a link. And then your credentialing and privileging pin, I've given you resource links here that you can just click on and access. These probably, you have all of these somewhere already at your health center. Here's your QI/QA resources. This HRSA has a very good quality toolbox with lots of resources in it. And then here's the ECRI. This has your clinical risk management program page. I have found recently, especially in new access points, that they are not fully informed of the ability of this resource, of the ECRI resource, and that it is provided free of charge for health centers. And through an access and login that you can be granted, you have access to a lot of resource materials, documents, policies, procedures, many, many things. And then the last is governance resources, and this is, I love this resource center. It's got strategic planning policies, processes, bylaws, checklists, many, many things in it. And I'd encourage you to take a moment after this presentation, and particularly before your OSV, to make sure you access all of these resource links. So let's go to scene 3. It's showtime. The tone and effectiveness of the OSV is directly impacted by your approach, your planning, and your preparation. As part of that, we have a cast of characters. We have leading characters and we have supporting characters. Let's talk about our main characters. The main characters, of course, is going to be the consultant team, and there's 3 consultants that will be on site with you. Your project officer may or may not be on site with you. Characters would be your board members, and as mentioned earlier, the more representation of board members, the better, but not required that all board members participate. We do understand their busy schedules. CEO, COO, CMO, CFO, and you may or may not have all of these positions. If you don't have the positions themselves, then it would be those staff people that are responsible for carrying out the activities. Billing manager, or someone in the billing department that could speak to your billing protocols. Person that's responsible for QI. Human resources, and the person responsible for carrying out credentialing and privileging activities. Supporting roles, everybody at the health center will play a supporting role of some sort in either planning, preparing, or actually during showtime. Other supporting roles that are appreciated is having someone in the health center, a health center contact, to assist consulting teams when they're on site. So if the team usually likes to stay together in a room, because like I said earlier, documents, where consultants will use documents across the different disciplines. And having a contact, whether it's an executive assistant or whomever it is, having someone that they can call upon should they have a question or need something is most appreciated. Information technology support, particularly if the consultants are going to need access to the health center internet or some other type of electronic format. Primary Care Association plays a supporting role, definitely. Props. Here's some of the key props. The 19 program requirements, for sure. Your site visit guide. The pins and pals. And there are multiple ones. I included some of the newer ones or more important ones that are definitely related to some of the challenging program requirements. A workable space for consultants to work, and as mentioned, usually they like to stay together. Internet access, sufficient electrical outlets or extension cords or something so that they can plug in the laptops. Documents. And a quiet space for interviews if available. If not available, that's fine. You know, again, consultants are very flexible. So let's test your OSV IQ before we close. These are all true, false, and I'm going to rate them, and I'm going to pause just for a second just so you can think about what your answer would be, and then I'll tell you the correct answer. Health centers receive an operational site visit only when there is a recognized problem or potential problem. The answer to that is false. Every health center receives an operational site visit, and as mentioned, for new access points, it's within the first 15 months of project start, and for all others, it's once within a project period. Health centers are expected to comply with all 19 program requirements. That is true. A program requirement is met only when all elements within the requirement are adequately satisfied. The answer is true. Previously, there was the opportunity to give a partially met, particularly in those program requirements like program requirement number 8 and number 17 that have multiple elements within it, but that's no longer possible. So it's met or it's not met, and met means all elements within the requirement have to be satisfied. The OSV site visit report is final at the time of the exit conference. The answer to that is false. The site visit report is completed by the consultant team, and it is submitted to the contracting consulting company for review, which is then reviewed by the project officer. There is some editing that goes on after the fact. That report is not final until it is sent to the health center, usually somewhere between, I'd say, an average of about 6 weeks, maybe a little bit longer. But just know that that report is not final at the time of the exit conference. What happens at the exit conference is the findings. The consultant team will go through each of the requirements and tell you if it's met or not met, and if it's not met, we'll give you some recommendations for resolve. It's encouraged that you take copious notes during that time, especially for the elements that are the requirements that haven't been met, so that you can begin action quickly and not have to wait for the final report to come, that you're already putting things in place to resolve. According to HRSA consultant teams, the average number of program requirements met during an OSV is between 12 to 14. The answer is true. There's usually 5 to 7 not mets that are found within a typical OSV. The site visit report contains findings, recommendations, and performance improvements. True or false? The answer is false. Prior to April of last year, the consultants were able to put in performance improvements. These would be things that even though you may have met the requirement, these are best practices or things the consultants have shared with you or want to share to make things, to actually make improvements upon an existing process. That is no longer part of the site visit report. However, the consultants can and are expected and encouraged to provide performance improvement while they're on site. And they will tell you, verbally tell you what these performance improvements are, but it's up to the health center to determine how best to use those and to make note of those. The purpose of the site visit is to assess and report compliance with all 19 requirements and report progress on at least one clinical measure and financial measure. The answer is true. Not only are the consultants looking at the 19 program requirements, the financial consultant will choose at least one of the financial measures, the HRSA financial measures, and talk with staff about how they're meeting it. If they're not meeting it, what kind of actions and things are being put in place to improve performance. And the clinical consultant will choose at least one clinical measure. Sometimes it's up to the clinical consultant to pick the measure, and sometimes the project officer and the health center have been following a particular measure over time, and that one might be selected. The best approach to an OSV is to keep participation and collaboration with the team to a minimum. I think everyone probably knows the answer to that, and that is false. It's encouraged that participation and collaboration is a maximum. So health center working with the team all the way from getting prepared, pre-site visit conference or call, and throughout the entire visit, is that there's a good camaraderie and collaborative and a positive spirit about the OSV. And that ends my presentation. We only have a few minutes for questions, but I'm happy to answer any questions that you might have.
I am going to one by one unmute each one of you so that you might have the ability to, you will have the ability to speak directly to Candy.
Your call is important to us, and we're doing our best to assist you. Please continue to hold. We'll be with you in just a moment.
Well, I need to figure out which one that is. Does anyone have any questions? Any questions at all? Okay.
We know your time.
With that, we will move now to the polling questions. If you don't mind, if you'll allow us to ask you a few questions, it helps us with our when we plan these webinars in the future. So if you will please, if you can just very quickly answer these polls, that would be extremely helpful to us. And by the way, while you're answering these polls, let me tell you that the reason we're doing these webinars is that at Quality First and PolicyPLUS, our goal is to assist you and your health center effectively navigate the many challenges you're facing. And you face these every day in gaining and maintaining compliance in many areas, and there's so many areas of the ever-increasing accountability. The reason that you're receiving this invitation is because of one of three reasons. Either you're a client of Quality First or PolicyPLUS, or you're considering becoming a client of Quality First and or PolicyPLUS. And the last reason is that we have select PCAs that see value in the services and the information that we provide, and they make our webinars available to their membership. So those are the reasons that you are actually in this webinar. Okay, I'm going to move on to the next one now. The next poll. Hopefully today you gained good, valuable information and saw value in the time that you spent. We try not to waste your time. We try to only provide you with information that's pertinent and timely for all of our clients and all of our health centers that we're working with. Hopefully we've been successful with that. Next, poll question. And by the way, the subjects that we speak about in our webinars, we get that from you. You tell us what's concerning you or where you need help or where you want information. And so we love feedback. I know both of our email addresses are attached either in the invitations and it's also going to be in the follow-up email that goes out. Give us your feedback. Tell us what do you want to hear. Where might you be struggling or needing a webinar put together for you? What would benefit you? And we'll take this information. This is how we decide. Last year we had a whole series on PCMH recognition, including the last one was the differences between 2011 and 2014. Many of you remember that, but we got that from you. You were the ones that told us what you needed to see, what you needed to learn about. One more question.